When we were preparing for the conference, we wanted to do things a little bit different, and one of those things that's coming up at the moment, we've got a panel discussion, and the chair for the panel discussion is Professor Charles Mitchell. So Charles, would you like to come up? And we have a number of guests for the panel, so I'd also like these people to come forward as well. It's Kristine Whorlow, Lutz, you can come back up. Dr. Mark Levy, Ms. Angela Francis, and Michele Goldman. If you make your way to the stage, and I'll let Charles to introduce the session.
Thanks, Peter. Three minutes then. 3 minutes. Hi. How are you? Do you want to lead off? Might be an idea, I think, since you've already kind of set the scene and you've got some, obviously some very clear thoughts on it. Good morning. So, as Peter said, I'm Charles Mitchell. I'm a respiratory physician, and I suspect the oldest respiratory physician in the room. If anybody wants to disagree with that, put their hand up. I have a long experience with asthma. I go back I started as an intern about 10 years before aerosol steroids or Becketide came out. So our session today is about how we're going to spend $50 million. It's not much in the grand scheme of things, but we've asked our eminent panel to come up with their top four. This is $50 million for a project, and you can either spend it in a week, a month, a year, or several years. And I think it would be appropriate to ask Mark to lead off. Another Mark Brook, who is somewhere up the back with his hands on a keyboard, is going to project on the screen each... oh, it's not you. You've got someone who's competent to do it. Yeah, that's good. So someone that can type. And that's good. So we're going to put up on the screen people's ideas. Obviously there'll be some similar views coming up, and at the end we're going to ask you to vote on what you think are the more important projects that we might support with this $50 million. So, Mark, do you want to up here or there? You feel more comfortable talking sitting down or standing up?
I'm happy to stay here.
Right.
Everybody's happy. So you want four things. I'd start off with ensuring that everybody with asthma has a self-management plan which is tailored to that individual. In particular, identification of trigger factors that spark that person's asthma off. So, for example, if someone's allergic to grass, then they should increase their medication before the hay fever season would be a logical thing to do. So top of the list would be self-management plans for everybody. And then next would be something I mentioned earlier, and that's ensuring that everybody is assessed after they've had an attack, irrespective of where they're treated. And that assessment should include an assessment of their current control and risk factors, and to identify what went wrong, why did that person end up having the attack. And then the doctor and the patient can work together, or the nurse and the patient work together to optimize their treatment. And then the next point would be to identify risk factors and identify those people when they're at risk and do something about it. So, for example, if somebody consults for an unrelated problem and they have a past history of asthma and they're not collecting prescriptions, or they not taking their medication adequately, then do something about it there and then, rather than waiting for an attack. And finally, I think we should take a lesson from Finland and get an ongoing, sustainable education program for both health professionals and people with asthma. It's no good just training doctors when they're in medical school and hope they'll carry on practicing good asthma care forever. It needs to be sustained, and the point at which that education can be delivered for patients is after their attacks, and for health professionals, if they use a system of medical audit, which is what is ingrained in the UK healthcare system, whereby the doctor assesses the patient to identify problems, address problems. It's a cycle, really. You address the problems and then you reassess to see whether the problems have been eliminated. And that would be my fourth idea.
Thank you very much, Mark. So I just push you a little bit before we move on, because we're still within the 3 minutes that you've been allocated. What would your project be? How would you've got this 50 million, how are you going to spend it? Where's it going to go?
Well, part of it needs to be on raising awareness, and I think that's what the National Review of Asthma Deaths has done. So if we can raise awareness amongst the population that simply using a blue inhaler is not enough, that this is a chronic disease, I think that's the key message to get across. Now, that might be through public media, through social media, just a simple message that asthma is a chronic disease, it's not a series of acute attacks. And then take each attack and label it as a failure of treatment. Now, how you do that, I don't know. I think probably got to get high-level government input into this. Okay. Or TV programs. I mean, popular TV programs could be used to emphasize the effect of uncontrolled asthma. I don't know if you can buy a TV program or write a script and get them to screen it, which could become... And we've got YouTube now, which does enable us to produce material which could go viral. So we need a couple of disasters, really, which are publicized, highly publicized, which emphasize missed opportunities and what could have been done.
Right, thank you. I think it's a very nice introduction to Kristine Whorlow. Kristine is CEO of the National Asthma Council. When it was called the National Asthma Campaign, Kristine and I worked very closely together. And Kristine, you're an expert on the impact of national television and other ways of educating the public and also educating doctors. So your 3 minutes starts now.
I always stand up because I'm short. I think to start with, and I'll come back to that point at the end, Charles, we mustn't overlook the significant progress we've made in the last few decades. Deaths obviously are down, hospital admissions and so on. And very importantly, asthma's been a national health priority, so Australian government recognition since '91, which has brought with us the most amazing program funding, not only for the asthma foundations and their work with people with asthma, but for the National Asthma Council and our work with health professionals. And we mustn't forget the Australian Centre for Asthma Monitoring. No other country in the world has such a resource. Now, we've achieved a lot of things, and we had so much asthma. I've also left out, of course, the Australian treatment guidelines, which we've had since 1990, well recognised, but as we all know, treatment guidelines are extremely hard to implement in practice. We know that adherence to medications is very disappointing for us all, and also that GPs in their incredibly busy environments find it very hard to adhere to the guidelines. I think we need to spend this 50 million, and we need to spend it as we're writing the next National Asthma Strategy. We need to spend it from 2016 to 2020 on some very important things. It's time in asthma to demand a cure, or at the minimum, demand effective primary prevention and/or deep remission for existing asthma. Early identification and early intervention is starting to be achieved in rheumatoid arthritis, and there are great advances in cancer, so why not asthma? How could we achieve this? With greater investment in basic research linked with clinical and translational research, we should form or join international consortia with clear goals and timelines. Ever since I've worked in this field, I've been told that NH and MRC funding for asthma or for lung disease is too small. Well, that should also be part of our expenditure, working out strategies to increase the asthma proportion of NH and MRC funding. Now, more than that, we need to spend some of our 50 million by throwing asthma up into the air. I refer to the Lancet Commission, which intends to do that. Just looking at the umbrella term asthma, and I quote from the Lancet, "The reason why, after 20 years, asthma has not advanced from the blue and brown inhaler, measurement of urinary cotinine, and looking menacingly at the pet cat." I share with Charles some history when I've had to defend the pet cat in the asthma world. It's now time to redefine asthma and develop new medicines for prevention, cure, or remission. Now, that's going to take quite a while, probably longer than the timeline I would like of 2020. So, in addition to our usual activities, we must spend a chunk of this 50 million, and I come back to the point made by Mark and emphasised by Charles. We must spend a chunk of this money on a long-term national program of public awareness and education about asthma and its management, and we must carefully evaluate this. We've had good campaigns before, and they've worked well in terms of evaluation, but they've been sporadic. I've always been jealous of the quit smoking campaigns. Every few years we see a really solid investment in national media campaigns. We need that in asthma. So, I want the 50 million to be spent on cure, new innovative medicines, perhaps a redefinition of asthma, and sustained consumer campaigns. These, alongside our current programs, which must be maintained, will really take us forward. Thank you.
Thank you, Kristine. Perhaps Angela Francis. Angela is CEO of Asthma New Zealand, and so I think we'll move to you next, and then Michele, and then have Lutz to finish.
Thank you. CEO of the Asthma Foundation of New Zealand, but I'd like to acknowledge my colleague Linda Thompson, who's here today from Asthma New Zealand. Tēnā koutou katoa. My feedback is based on a New Zealand perspective. So firstly, I would like to see extensive funding into a lobbying and advocacy campaign for our politicians and government officials in two ways. Firstly, to upwardly influence the social determinants of health, given the correlation between asthma and social determinants of health. I think we can't make any gains of a longer term nature until these are addressed. And these include poverty, housing, for example. We believe that every child has a right to a well-insulated, well-heated and well-ventilated home. The second area for lobbying in New Zealand would really be for asthma to become a health target. We believe that until it becomes a government priority, we will continue to see the trending that we're seeing. We think with an emphasis on asthma on the political and health agendas, that we would then naturally see an onflow to increased funding that is appropriate. For example, having updated guidelines. Currently, these are 12 years out of date. Also an emphasis on the care continuum and integrated approach, primary, secondary, tertiary, etc. Secondly, an increase of funding into tobacco control and smoking cessation, and whilst that is reasonably well funded, I believe it could be more so. I concur with Kristine's comments. Funding into research, particularly into cure for asthma, would be something that we would like to see. Thirdly, having free annual asthma reviews for those with asthma is critical. And lastly, having, and this is something Mark has mentioned a couple of times now, national televised health promotion campaign, awareness campaign, with emphasis on treatment. For example, being registered with a primary care provider, having an asthma management plan and adhering to that, and taking medication as prescribed. And that's it. Thank you.
Thank you, Angela. Michele. Now, Michele Goldman, if you want to know more about these people, they're all written up in your booklet, so this is why my introductions are extremely brief. But Michele is the CEO of the Asthma Foundation of New South Wales. Thanks.
So having $50 million to spend on asthma is a great opportunity. I think the comments that have been made about having an integrated and sustained campaign over a period of time is critical. You could spend a lot of money in a short time and maybe have a blip, but I think we all know that changing outcomes for people with asthma is hard, and I acknowledge, as Kristine said, hospitalisations and deaths have declined, but progress has really stagnated. So if I had $50 million to spend, the 4 top initiatives that I think I would spend it on would be further increasing access to evidence-based and user-friendly information via the Asthma Foundation services as a start. We have some fantastic services online via telephone support, face-to-face in the community, but not enough resources to get really meaningful reach. So we would be able to, with increased funding, increase awareness for these services amongst patients, but also importantly, health professionals. We saw in the first presentation today about the deaths review just how patients are falling through the cracks. So if we could build referrals from hospitals, from doctors to community organisations like the Asthma Foundation, then we can pick up with patients, see how they're going, explain the importance of their medication, and help them on the journey to good control. The second area would be deploying the GASP program into practice nurse-led clinics around Australia. GASP stands for Giving Asthma Support to Patients, and you're going to be fortunate to be able to learn more about the program later today, so I'd encourage you to go to the GASP session. But just very quickly, it is a decision support software tool accompanied with comprehensive training for practice nurses and, importantly, ongoing support to help build their confidence in implementing this new system in primary care. And I think the first few presentations today have really highlighted how important it is to make sure nurses are well trained and that they do have a system which is consistent with the guidelines. So patients are having spirometry, they are being issued self-management plans, they are being given information about their triggers. So I'm very excited about GASP. We're about to pilot it in New South Wales, and I think that it is something that could achieve different outcomes in Australia. The third area would be making medications more affordable and effective. We saw that maybe cost of medications is not the primary self-reported reason for being a barrier to taking medications, but it is an important one. And I think the PBS could be restructured in a way without costing the government any more to make medications more affordable if we were just able to improve prescribing practices. So 70% or thereabouts of patients are prescribed combination therapies when probably only 20% of them need it. The government's paying a lot more money for these medications, so if we could shift prescribing behaviours, the savings could be used to make all asthma medications cheaper. And I think in terms of making medications more effective, a really sustained education campaign around correct inhaler technique, making sure both or all health professionals are aware of correct and trained in correct inhaler technique, and that whenever a patient has a consult with a GP or whenever they're fulfilling a script in the pharmacist, with their pharmacist, that their technique is reviewed. And finally, I would put a lot more resource into running advocacy and education programs to reduce exposure for people with asthma to environmental triggers that are both cause and exacerbate asthma, and particularly tobacco smoke, which we've seen the importance of smoking cessation, but also air pollution, which is a major cause. And we've seen some success in changing legislation as a result of concerted campaigns, legislating against smoking in cars with children, banning smoking in public places. So more work can be done in that area with successful outcomes. And I think in terms of air pollution, we need to see new standards which limit the amount of harmful pollutants, and also improve our monitoring so we have a true indication of the quality of our air. So those would be my 4 initiatives.
Thank you, Michele. And last but not least, Lutz.
I've already given some of my suggestions at the end of the talk, so it can be shorter. I stick to it. I would form an alliance with the smoking cessation program. They are currently, they're successful, they're well funded, and in New Zealand, asthma needs to become one of the health priorities. And a good way forward is probably to use some of our $50 million to support them and use some of their kudos that breathing is part of smoking cessation. I also just back that people do need a clear diagnosis of asthma, and I would probably provide healthcare providers with spirometry rather than training everybody in spirometry. I think training can be better done. For the third point, as I alluded, training community providers, pharmacists. I'm very interested in the gas program. I have to come to Australia to learn about the New Zealand program, so I'm looking forward to your talk this afternoon. You're going to ask me a specific question. I might try to pilot with one of the Maori providers. The same way, if you roll up to a smoking cessation program, you get free nicotine patches. That's the way sort of New Zealand works. Why not, if you roll up into with a provider, you get a free beclomethasone salbutamol inhaler? It costs virtually nothing. So in this way, provide free medicines to people who need it. And so the community programs is where I would spend the bulk of my money with, and the advocacy I would work together with the smoking cessation programs.
Thank you very much. I'm having trouble kind of bringing some of these thoughts together, but I will try to now give us a list, and then I think we'll go to a vote, and then we'll see how that goes, and then perhaps come to back to the panel for a final comment. Unless anyone on the panel has any comment now about someone else's list. Mark?
Just one comment. Angela suggested an annual asthma review for everybody. And I think we need to get away from that, because asthma is there all the time, not just once a year. And there is the perception that if you do an annual review, then that's all you need to do. So I would change that to an opportunistic review at every opportunity.
Right, thank you. So I think what I'd like to try to do is to put up a short list on a basis of what I've heard. The first is that we make sure that everyone who needs an asthma management plan has one. So if we can type some of these up now, that'd be good. That and I'd include in that people who've been admitted to hospital with acute asthma, because they clearly need one. We can group those together. I've heard a fair bit on risk factors for asthma, and I've heard a bit on risk factors for poor control. So how do you identify those people who really need more attention so that they might be registered and have more ready access to services because they are demonstrably non-adherent? They don't keep appointments. How do we manage that group of people that, I guess in Mark's review, were fairly common by the look of it, Mark? Number two, I've heard about the cost of treatment and whether we could have something that enabled particularly those who are socially disadvantaged to have more ready access to particularly preventer medications. And there are some countries in the world where you register a chronic disease and they have treatment which is at a reduced cost to the average. And I think Denmark is one such country that does that well for diseases like asthma, hypertension, diabetes. I've heard about research to identify causes and how to prevent asthma, or primary prevention, in other words, stopping people getting it in the first place. And Kristine put forward such a proposal, acknowledging, I think, a very important thing is that our research budget in Australia is relatively small and we can only do it in a sort of international collaborative, but pound for pound, population-based and on GDP, the output of Australian research for asthma is a leader. So we need to be in there, but one of part of an international group. Smoking, doing more for smoking. I think I'll just leave it at that. And I'm going to throw in that patients with asthma should have a more detailed assessment, which will help, and I'm going to put spirometry into that basket. Have I left anything out that's really dear to any of your hearts that should be in there? Yep. Go, Angela.
I just think unless we seriously look at the social determinants of health, we will continue to see the poor trending in asthma rates.
So you want more than recognising people with asthma who are socially disadvantaged to help them?
I think if we turn it around and say that if they had sustainable income levels, well-ventilated, well-heated and well-insulated housing,
okay, let's throw that into that,
to healthcare,
into the group that I
access
proposed.
to healthcare.
Clearly the social determinants of illness and health and poor management are well recognised, and they apply to all diseases, be they chronic or acute, don't they? So,
correct.
Let's just say that we need to provide support for socially disadvantaged and leave it at that for the moment. And you had another point?
Yeah, just that national awareness campaign around education.
So what's the focus of that campaign?
Well, the emphasis on the three key messages for asthma control, which is being registered with a GP or primary care provider, having an asthma management plan and taking medication as prescribed. And
okay, so the issue of how do we get to people with asthma and more general people in the community to emphasise the importance of asthma control as a kind of a more objective measure rather than the subjective measure that we've heard about how well controlled is your asthma, which doesn't mean anything. Okay, and Mark?
Well, the other point which a number of people brought up was to do with public awareness. If somebody walks into a casualty department and says they've got chest pain, they'll have 15 health professionals jumping on top of them and doing something, whereas somebody ends up in casualty with an asthma attack and they're just nebulized and sent out again. So it's to raise awareness of the seriousness of an asthma attack.
Okay.
You know, in the UK, I can't remember this program on stroke. There's 4 letters which they use, fire or something like that. If we can come up with an algorithm that alerts the public, a nice, easy algorithm that alerts
All right.
people.
Let's add it to the list, which is that increasing awareness amongst in healthcare systems that asthma needs to be managed more urgently and more effectively than it is, which includes the post-discharge management as well. And Michele, last one.
Access to ongoing information and support, whether it be, reassurance or information, and that needs to be both inbound and outbound, because I think we've got 2 particular segments in the community, those that are actively seeking information, and we want to help provide that to them, but also importantly, those that are falling through the cracks, and we've got to find, construct a path.
Can I put that into the top one, which is that everyone needs an asthma management action
I
plan?
think it's much broader
and within that
Yep.
is access to appropriate information for them and their family or carers. I'm just trying to reduce the list a bit.
Yeah.
You've got a bigger chance of getting it up if it goes in with that, I think. She doesn't look supportive, so we'll leave it in.
I think it's much broader than just a plan.
All right, so we have 1, 2, 3, 4, 5, 6, 7, 8. Everybody in the room gets 2 votes. Mark, do you want to come up here and help me count? No, come on. No, I need one more. So, show of hands. So, the first one is everyone who needs an asthma action plan has one, and some of the broader issues around that, available, appropriate education and understanding. So, hands up those that want to spend some of their 50 million on that. So, okay, I'm just a very rough count. So it's no, 20. 20. No, it's 20.
Who's running the show?
I am. 25.
48.
Okay.
48.
28. Okay, thank you.
Not talking about your age.
No. All right, so the next one is the cost of treatment, particularly to enable socially disadvantaged access to preventer medication and providing support to socially disadvantaged. Considerably less, that's interesting. Goodness gracious, I'm surprised that you... All right, I'd say about 15.
27.
27? Okay, primary research against preventing asthma from occurring in the first place as an international collaborative.
Put 2 hands down, Jill. 58.
58? God. Doing more for smoking cessation. We're talking about asthma here. 10.
14.
Patients with asthma should have more detailed assessment, including spirometry.
42.
Thank you. Awareness campaigns, national. Primary care provider action plans, adherence to treatment. So this is all about a pub to the primary care provider. Can we just say a lot?
163.
163. Gosh, you're quick. Okay, 163. It's amazing, Mark. Raised awareness of the seriousness of asthma attack, both publicly and within healthcare systems, so that patients like those with a heart attack get better managed.
So 163.
access for people with asthma and their families and carers for ongoing information, education and support. $28.
41.
Right. So now, I don't know whether our panel can see those or not, but it's clear that the first cab off the rank are 6 and 7. Awareness campaigns, primary care providers, and asthma action plans and adherence to treatment, and raising the awareness of the seriousness of an asthma attack, both in terms of its acute management and management thereafter. If I could then maybe just be selective now, Mark, if that were where the funding went, what would be your outcome measures on which you would judge the intervention to be successful or not?
I would say reduction in asthma attacks, so the number of asthma attacks, so the number of people that we treat with high-dose prednisolone or who are admitted to hospital or seen in emergency departments, coupled with asthma deaths, obviously.
Okay, thank you. It's off my screen now, but the next, can we just go back to the previous screen, please? Thank you. And so the next cab off the rank looks to be research, primary prevention of asthma. Kristine, this was your baby. One has to take a long-term view here. This isn't something that's going to happen tomorrow. It's going to be something that happens quite in the distant future. And your outcome measure?
Well, my outcome measure is cure, or primary prevention, or something that will bring about remission. But I find all that a bit too hard. But I think if we were to work towards that, we would have a plan over a number of years. You know my goal, 2020. But it would have to have, knowing all this takes a very long time, we just have to set milestones and goals as we went along. But okay, we are aiming for the big result in the end. I can't say more than that. I mean, no, I'm not a scientist.
And I think it's difficult because asthma clearly is a multifactorial disease. I mean, there are genetic aspects, there are environmental aspects, and they differ from patient to patient. There are some common themes. So it's highly unlikely that we're going to cure all asthma, even if we do come up with some a treatment which is effective. So that's fine. I think we do have to move the goalposts as we go. The next cab off the rank looks to be everyone needs an asthma action plan. Now, we've tried this, haven't we, Kristine? And we all know that if people have them, they're effective. But getting penetration is extremely difficult.
We have the best penetration in the world, 40% of children and 25% of all ages. It's fantastic. Of course, we don't think so. We work here. We're trying to make it happen. It's fantastic. Can we increase it? I don't know. I hope so. But we are measuring action plan ownership by this. We're not measuring action plan use, nor are we measuring how the action plans were delivered. And the level 1 evidence about action plans is that they are delivered with education. We have no assurance that that is happening. So we have to be very careful when we're talking about our action plan figures.
Can I make a comment, Charles?
Michele?
That GASP aims to address a lot of those things because it would be the practice nurse who's spending 30 minutes or so with a patient and developing a tailored asthma action plan for them. So you're getting the plan plus the education and then review later on to ensure that it is being used.
All right, and I think that's probably a good point to finish. GUSP sounds a very exciting sort of pilot. I wish you well. We know that doctors are hopeless at following guidelines. We know that nurses and pharmacists are much better. Pharmacists are terrific because most of them have got OCD and and they're really good at checklists and making sure that all the important things are done. Doctors do it by the seat of their pants and the way they feel on the day, and they're hopeless at following guidelines. So I think if we're going to get anywhere with guidelines and their implementation, we have to involve more than the medical profession. And to do that, I think we need people who are expert communicators, who understand what the important issues are, and we need to get them working with doctors to help doctors to do the right thing. So I think on that note, we might leave it. Lunch is calling. I'd just like you to join me in thanking the panel. Until we meet again. So, Peter, you want to say anything?
I do, Charles. I just want to thank you very much for chairing the session. People may not know that Charles Mitchell was, until recently, the chair of Asthma Foundation Queensland and has spent more years than probably what he cares to remember on the Asthma Foundation Queensland board. So we're certainly very indebted to him, and thank you very much for chairing the session today. So, and can you also please once again thank Kristine, Lutz, Mark, Angela and Michele as they leave the stage. It's almost time for lunch, and I'd please just want to acknowledge Mundi Farmer, one of our presenting partners for the conference, who are sponsoring lunch today. So please enjoy lunch, and we'll see